Almost any problem becomes more manageable when you have a framework for understanding and addressing it. Hello, Queensland. I'm Tony Pisani, a clinical psychologist with a focus on suicide prevention, and one of the developers of Prevention-Oriented Risk Formulation.
Hi, I lead the lived experience faculty at SafeSide. I'm a suicide attempt survivor myself and an advocate for recovery-oriented care. I co-teach and collaborate with Tony Mel and others on SafeSide's programs.
The Gold Coast has been leading the world in zero suicide and in the application and enrichment of prevention-oriented risk formulation. It's been really gratifying to be part of that work and to learn from the leaders and staff I've interacted with at Gold Coast Health.
We wanted to share a few things we've learned from applying prevention-oriented risk formulation in many health systems.
First, we increasingly teach and see teams using risk formulation to engage and communicate directly with consumers and family members.
Families are often acutely aware of context as it relates to risk for their loved one, such as what foreseeable changes are important to be aware of. These are generally the things that we as family members worry about too. We use our lived experience to know what to look for. We can help articulate these changes and plan for them, if and when the consumer cannot. This also brings clarity and transparency to the process for consumers. Often those who struggle with suicide concerns are already feeling a lack of control over their lives. When decisions about risk happen behind the scenes, it can leave consumers feeling even less in control and disempowered. With prevention-oriented risk formulation, you can more naturally talk with me the same way you talk about me.
Second, the principles behind prevention-oriented risk formulation are being applied to prevention with many kinds of risks, not just suicide. Risk status and risk state actually originated in the violence literature, and my colleague and forensic psychologist Dan Murray has helped us learn how to apply the model clinically to risk for violence.
Across 123 rigorous studies, 2 points came out clearly. First, aggression and self-harm frequently co-occur. Second, from an empirical perspective, there really aren't any factors that the researchers could identify that would distinguish whether a patient is at risk for one type of harm or the other. Across 123 studies, there was still no information they could use to say this patient should only be assessed for one type of harm and not the other. So from this, the authors concluded that concerns about one type of violence risk should always prompt us to screen for the other.
Teams in other settings we work with are drawing on formulation for other kinds of risks and vulnerabilities as well.
Third, and this one is really important to me, our framework has expanded beyond assessment to include how we respond to risk, including ensuring that whatever may be driving a person to feel suicidal gets addressed.
Yes, and this is critical to document. Right along with foreseeable changes and available resources, we should identify drivers and how they'll be addressed in a care plan. Okay, we wish you well, and we're grateful to be on this journey with you towards zero suicide.